gestational diabetes mellitus, which is now known as HIP or hyperglycemia in pregnancy. You've tested the woman, you figured out that she has high blood sugars, you have advised her about the implications to her and her baby, and you have also instituted the medical nutritional therapy, the lifestyle changes, the diet and exercises, and you are now going on to the surveillance both of the mother and the child. The primary goal of management of the pregnant women with high blood sugar is to ensure the normal process of pregnancy, of course, and we want the best of the outcomes both for the mother and the baby. This can be done by controlling the mother's hyperglycemia, because it's her high sugars that is causing all the problems to the environment of the fetus, and it can get her and her baby into trouble. So controlling her sugar is one of the main aim, and also to prevent the hypoglycemia, because over treatment would lead to the opposite extreme. The routine antenatal visits, which we say once in 4 weeks, are no longer the rule in case of gestational diabetes mellitus. Those whose blood sugars are well controlled need to be seen as frequently as once in 2 to 3 weeks. Uncontrolled sugar levels are of course to be seen much more frequently and sometimes need admission as well. So the uncontrolled sugars, they may have comorbidities like high blood pressure, proteinuria, large sized baby, excessive amniotic fluid, etc. And all of these, as you recognize, need extra antenatal surveillance. And every weekly in the 3rd trimester is the rule. So you can well imagine that testing 30 million pregnant women in the country twice in pregnancy is a huge resource intensive exercise as it is, but those 3 to 5 million who are diagnosed as cases of hyperglycemia in pregnancy need a special clinic called the DIP clinic, or the Diabetes in Pregnancy Clinic, because there are several things in the frequent surveillance that you need to do with respect to both the mother and the child. For the mother, you would check the weight, the blood pressure, the urine for protein, blood sugar by glucometer or the laboratory analysis, and most of these things will need to be done very vigilantly. So the healthcare provider also needs to be sensitized and trained for the same. If the mother is self-injecting the insulin, or somebody in her family is giving her the insulin, they need to be also told about the possibility of hypoglycemic episodes, because oftentimes in pregnancy they will take the injection but they will not be able to eat the food in the manner that it should be, and they may have hypoglycemic episodes, and that needs to be taken care of in its own merit. The effects on the fetus are largely because the placenta allows free transfer of excessive maternal glucose to the fetus. Subsequent stimulation of the fetal pancreas will happen. The trigger is the fetal hyperinsulinemia, which precipitates into short-term complications such as the macrosomia, or the large for gestational age baby, and neonatal hypoglycemia. This does not end here with the short term. There are also long term consequences like later development of childhood obesity and the early onset adulthood diabetes. The fetal risk, of course, span the entire spectrum of pregnancy. If the sugars are high in the early part of pregnancy, there are chances of congenital anomalies much more than in the normal population. Early pregnancy losses or abortions, preterm labor, the macrosomia, shoulder dystocia, and birth trauma. Ultrasound, of course, is one of the mainstay in the assessment and surveillance of the fetus. The first visit, we would be doing an early pregnancy scan to establish the viability and the dating, which is so very crucial, which is best done anywhere around 7 to 8 weeks. Then the standard 11 to 13.5 week scan, which is the same as the NT scan. 17 to 19 weeks is the anomaly scan, because we prefer an early anomaly scan, especially in uncontrolled sugars. There could be high chances of fetal anomalies. At 22 to 24 weeks, we always double it up with a fetal echo, and of course from the 28th week onwards, in a graded way, we track the growth of the baby, the abdominal circumference being one of the most important measures. So, though there is no standardized protocol for fetal surveillance, generally the scans are done at 28 weeks, 32 weeks and 36 weeks. Prevalence of malformations appears to increase with the degree of diabetic severity prior to the pregnancy. 3 to 4-fold increase in the incidence of congenital anomalies in the pregnancies that are compromised by the pre-GDM status compared to the general population. For example, the incidence of neural tube defects is as high as 20 per thousand in the hyperglycemia in pregnancy compared to just 2 per thousand in the non-diabetic population. So, also the cardiac anomalies, they are as high as 27 per thousand in those with high sugars compared to 8 per thousand in the general population. The most common cardiac anomalies in the fetus of the diabetic mothers are transposition of the great vessels, the ventricular septal defects, the coarctation of aorta and the single ventricle. So, the anomaly scan at 18 weeks, assessing the intracranial structure and the spine, and the fetal echo at around 22 weeks for the cardiac evaluation, both the 4-chamber and the outflow tract is a rule. To check on the fetal growth, we oftentimes rely on the ultrasound scan, as the accuracy of the measurement is going to be many folds greater than the funnel height measurements or just the clinical check on abdominal palpation. There is no defined structure as to how frequently you would scan. It will of course depend on your clinical suspicion, but by and large once in 4 weeks is the expected frequency to track the baby's growth. It was shown that when the abdominal circumference is greater than 90th percentile, fetal macrosomia was present approximately in 78% of the neonates. So, pay attention to the abdominal circumference in particular, and even though the absolute values of sugars may be in the range that is expected, if the AC is higher and more than 90th percentile, you may have to more strictly regulate her glycemic control. How good is ultrasound in predicting the fetal weight? Because this is one of the main determinant factors about the mode of delivery. Well, the large size of the baby, the errors in estimation are increased with the obesity of the mother, because the measures cannot be picked up very accurately. The result of the increased fetal mass, sometimes it gives rise to underestimation or overestimation, but you will generally have a ballpark idea of which way your decision should go as far as the intervention, both the timing and the mode of delivery are concerned. Macrosomia also needs to be defined as per the institution. If you take an average of all babies born at your own institute and mark the 90th percentile, anything above that is the macrosomic baby in the country context or in the institutional context, depending on the socioeconomic strata and the geographies in India, where different communities have different structure in their parents themselves. The macrosomic or large for gestational age babies are more prone to fetal hypoxia, sudden intrauterine death, the brachial plexus injury. Shoulder dystocia is one of the commonest problems that one would face when a vaginal birth is attempted. What is the role of umbilical artery Doppler? Those which have complicated with the high sugars and the vascular disease, greater impedance in the umbilical artery is a rule as compared to uncomplicated diabetic pregnancies. So, when this happens, you would expect that there will be less blood supply because of less placental perfusion, and typically an asymmetric or disproportional growth restricted fetus will be the fallout of this situation. The follow-up of the small for gestational age babies, biweekly sonographic and Doppler studies of both the uterine artery and the umbilical vessels is a rule, because any time the situation can change for the worse and you may need to intervene when you figure out that the baby is being decompensated. The clinical examination, the growth profiles, the biophysical profile and the non-stress test from 32 weeks onwards comprehensively will help you decide, based also on the fact whether the mother's sugars are poorly controlled or well controlled, whether she is purely on diet control and managing her sugars, or whether already the insulin therapy has been instituted, whether the baby is very large and you have to decide on the time and mode of delivery sooner than later, and of course a combination of all of these with a flat CTG will prompt you for intervention. The general guidelines and principles during labor are: there is a delayed lung maturity in the pregnancies with the gestational diabetes, hence routine delivery before 38-39 weeks is not recommended. In pregnant women with gestational diabetes, between 24 to 34 weeks of pregnancy and requiring early delivery, antenatal steroid should be given as per the Government of India guidelines, but this may increase the blood sugars, so appropriate regulations have to be done around that time. Injection dexamethasone 8 mg 12 hourly for 2 consecutive days should be given. Glucose monitoring closely for 72 hours after the steroid injection, and if the blood glucose is raised during this period, very short period of time insulin therapy may also be needed. Vaginal delivery should be preferred unless there is an obstetric indication for LSCS. But by and large in clinical practice, it's oftentimes a case of infertility or an elderly women with a large baby with comorbidities like preeclamptic toxemia, for example. All of these will oftentimes precipitate a operative delivery, and the threshold for the obstetrician to decide on the mode of delivery favoring towards a cesarean section is really very low. Timing of delivery, again we urge you not to take action before 38 weeks if all is going well. Expectant management even until 40 weeks or term, or induction at 38 weeks if she is on diet and exercise control with no complication. GDM on insulin needs an induction definitely at around 38 weeks, because the more time elapses, the more chances of shoulder dystocia and the possibility of fetal injuries. Complications with comorbidities such as hypertensive disorders or previous stillbirths, most of the times the balance of decision making is tilted in favor of an elective planned delivery rather than a prolonged normal delivery. So all in all, the essence of this entire dialogue is that every case needs attention, every case needs individualization, and there are multiplicity of factors which you have to take into consideration to finally zero down on the time and mode of delivery.